active member of the team and of the endemic medicine department. So welcome, Dr. Tamer, please.
Bismillahirrahmanirrahim. First of all, many thanks for you, Professor Maher, for your kind introduction, and many thanks for Professor Ahmed Rai for his kind invitation, and for our dear distinguished French professors. Bienvenue à notre invité et distingué professeur. Je vous souhaite un bon séjour en Égypte et c'est un honneur de vous accueillir en Égypte. Merci beaucoup. So, my lecture is about answering a common question since my long-term experience in capsule endoscopy. It's expensive procedure here in Egypt. It's not sponsored. It's a problem. So the questions always is about how to select your patients. If I have a patient who is in need for capsule endoscopy, can you guarantee that it will give positive findings or not? It's a difficult question to answer. And the second common question, if capsule endoscopy is purely diagnostic, why not to proceed with, for example, double balloon enteroscopy from the start that carries a diagnostic and therapeutic role? So that's an answer for these questions, the role of capsule endoscopy. Starting as an introduction, it started the capsule endoscopy, its journey since August 2001. And I like the first name of capsule endoscopy when it was M2A. That meant at that time mouth to anus for the first time to have a diagnostic tool that's non-invasive and can investigate the small bowel length of 5 meters that were called the black box, and it was FDA approved. All these capsule endoscopes were present in Egypt actually, but the current one that's present in Egypt, the Mirocam, is present here since maybe more than 5 or 6 years, and actually it carries the longer battery life and the better field of view. And there are some editions of capsule endoscopy, for example, certain ones for colon and for esophagus and the Crohn's disease and the capsule cam. Okay. So about indications, the first and the most common indication for capsule endoscopy is the obscure GI bleeding that can be overt bleeding, occult bleeding, or iron deficiency anemia, the chronic diarrhea, suspected and follow-up of Crohn's disease patients, suspected small intestinal tumors, and surveillance in patients with polyposis syndromes, suspected or refractory malabsorptive syndromes, and certainly celiac disease, and evaluation of side effects of NSAIDs. And other less common indications, unexplained chronic abdominal pain, and we have several patients who were first time diagnosed with lymphoma due to chronic abdominal pain and Crohn's disease also, diffuse intestinal disorders, limited applicability of esophageal diseases, and screening for colorectal cancer using certain capsule endoscopes. And concerning the advantages that are carried with the capsule endoscopy is the high diagnostic yield, up to 85%, high positive predictive value and negative predictive value. It's a non-invasive technique, and you can visualize the whole small bowel in up to 90% of patients. Guidance to the next management, and I think this is the cornerstone importance of capsule endoscopy, that it can guide for the endoscopic, surgical, or medical management, and lower bleeding rate if capsule endoscopy is negative. But for limitations, that's important, it lacks totally therapeutic capabilities, inability to control its movement apart from certain prototypes that are working currently nowadays, difficulty in localizing the lesion. I can't mention, for example, that the lesion I found is, for example, 15 centimeters or 20 centimeters away from the pyloric ring, but I am giving a region, for example, proximal mid or late jejunum, proximal mid or late ileum, but I cannot definitely know where am I. Lack of specificity, that's, for example, for healthy volunteers, 14% of incidental findings like angioectatic lesions that were non-significant. And by our experience, failure to identify the major papilla, the capsule endoscopy is not a tool to diagnose the duodenal lesions. For example, the major papilla, and it's a large one, and it can be missed in many capsule endoscopy examinations. About its safety, it's almost totally safe, but we have to take care for patients who are known or suspected GI obstruction, strictures, or fistulas. So for patients, for example, with Crohn's disease, we are asking them first to do MR angiography to make sure that the bowel has no strictures. Patients with cardiac pacemakers, but currently we are working with patients with cardiac pacemakers and no interference. Patients with swallowing disorders, and still we can introduce it in different manners, and pregnant women because we do not have studies about safety in them. Importantly, talking about the diagnostic yield and the clinical impact of capsule endoscopy, I will mention, I think, 5 studies that I found them cornerstones and important. For example, this one that was published in 2020 about the clinical impact of small bowel capsule endoscopy in obscure GI bleeding. They performed capsule endoscopy for 224 patients, and they found that the diagnostic yield was around 62%. So that answers the main question, how often you are going to diagnose lesions using capsule endoscopy. It's around 62%. Of course, higher in patients with obscure GI bleeding that's due to active bleeding, that's up to 75%, and it declines to 37% if I'm talking just about iron deficiency anemia. And what do you expect as lesions? Of course, the commonest lesion will be the angioectatic lesions, followed by small bowel tumors, Crohn's disease, and the NSAID-induced enteritis, radiation enteritis, and fresh blood. The second common question I am asked about, do you expect to find lesions in such a patient with obscure GI bleeding? If the patient is on anticoagulant or antiplatelet drug intake, the odds ratio is 6.7. That means he has almost 7 times more capability that we can reach a diagnosis. Also, the patients with anemia, if hemoglobin is less than 10, and more if it's less than 7. Concerning the age more than 50 and male gender and NSAID use, it proved to be positive in univariate analysis, but not with multivariate analysis. As we mentioned that the capsule endoscopy can guide for the second line of treatment that you are going to proceed. So for angioectatic lesions, you can proceed with endoscopic surgery or medical therapy. Crohn's disease, of course, that's a specific medical treatment. Small bowel tumors, that means you are going to do resection. And parasitosis, for example, a specific medical treatment, NSAID enteritis, NSAID withdrawal. What I mean here is that not all solutions will be performed using a double balloon endoscopy. Certain solutions can be with medical therapy and with surgical interference, and of course, as we mentioned, with endoscopic therapy. The second important paper is about the diagnostic yields and clinical impacts of capsule endoscopy, and they included several trials and meta-analysis. And I found some important messages. The first one is about the diagnostic yield of capsule endoscopy is 61.7%. That means almost similar to the previous study, versus double balloon endoscopy 55%. But importantly, if you are proceeding with double balloon endoscopy after a positive finding that was mentioned in capsule endoscopy, 75% likelihood that you will find the lesion. But if you proceeded while capsule endoscopy was negative, this will drop to 27%. Second important message, if you are performing capsule endoscopy for a patient with ongoing overt bleeding, he is in bleeding very recently, 92% you will find the lesion. If you are waiting for the patient and he was managed, and then, for example, after 3 or 4 weeks you are asking for capsule endoscopy, this will drop to 13% only that you will find the lesion. While patients with iron deficiency anemia and the fecal occult blood test positive, it will be around 44%. So that's the answer when a patient is asking me, will I find a lesion in small bowel using capsule endoscopy? If he's in active bleeding, it's 92%. Previous history of bleeding, it's around 13%. And for occult bleeding, it's around 44%. The third paper is about rebleeding, and it's predicted after capsule endoscopy in patients with obscure GI bleeding in long-term follow-up. They found angiodysplastic lesions and abnormal vascular lesions in the majority, and the predictors were the presence of cirrhosis. Incomplete capsule endoscopy visualization, of course, it can miss lesions, and the previous GI bleeding. If these 3 factors are present, you can expect a rebleeding after capsule endoscopy. And in that algorithm, for patients with negative capsule endoscopy from the start, the incidence of rebleeding is around 20%. Patients with positive capsule endoscopy, if they received a specific treatment and they were managed for their lesions, rebleeding is around 25%. But of course, if you found a lesion in capsule endoscopy and the patient didn't perform any specific treatment, so the rebleeding rate will be very high, up to half of the patients will bleed again. Again, as we mentioned before, angiodysplastic lesions can be managed by argon plasma coagulation or hemoclips, surgical treatment for small bowel tumors and the AV malformations, and the embolization for actively bleeding abnormal vessels. And if you are proceeding And we like to perform embolization for patients who are in a state of excessive bleeding and active bleeding at the time. Don't proceed for capsule endoscopy. That will take too much time to diagnose, and you have to proceed immediately for embolization. And medical treatment, it's reserved for patients for NSAID enteropathy, hereditary hemorrhagic telangiectasias, and Crohn's disease. Then a paper is talking about the video capsule endoscopy as the initial examination for overt obscure GI bleeding. Such patients, there were 89 patients with overt bleeding who performed capsule endoscopy. If they found a suspicious lesions, double balloon enteroscopy is performed. And it can be guided to be antegrade or retrograde route according to the findings of capsule endoscopy. So you do not have to proceed from upper and lower routes. One of them can be efficient according to the findings of capsule endoscopy. And of course, sensitivity and specificity are very high, up to 85 and 100%. Lesions and the discrepancies that happened in that paper between capsule endoscopy and double balloon enteroscopy, that the the same patients, 9 of them, capsule endoscopy mentioned the presence of duolephoid lesions. 6 of them were found with double balloon. Angioectatic lesions, all of them were seen. Erosions were more commonly found in capsule endoscopy. Ulcers almost the same. Polyps and AV malformations and gastric tumors, while double balloon missed the presence of jejunal verix that was seen by capsule endoscopy. Then my last paper that we published, I think more than 10 years ago, was about our first experience with capsule endoscopy and its role. And we found that 74% of our patients with overt bleeding were diagnosed with capsule endoscopy, while that dropped to 26% in obscure occult bleeding. And again, the commonest lesions were angiodysplastic lesions and fresh blood. And the impact of capsule endoscopy is that 30% were guided for further endoscopic management, and a percentage lesser than this for surgical management, multi-management, and the medical treatment accounted for 30% of our patients. And to increase the diagnostic yield, we have to look for patients with overt bleeding than occult, capsule endoscopy within 1 or 2 weeks from the previous bleeding episode, severe anemia and increased transfusion requirements, increasing age, and anticoagulation therapy. All of these factors, if they are present, possibility to find the lesions will be so high. What about negative capsule endoscopy? In that paper that was published in 2013, they gathered patients from around 700 capsule studies. 30% of them were negative. And among them, we found that 26 out of 34 patients with obscure GI bleeding recurred bleeding again, and 8 with obscure bleeding. So 8 from the total of 207. That means that it's a minor incidence that the patients will suffer from rebleeding if it's an occult bleeding. And if we are finding blood only but without lesions, still it's a positive finding because it can guide you for the possible site you have to search and to look for by the second endoscopic technique. I will mention some case presentations about capsule endoscopy and their findings and how it guided for the second line of treatment. For example, that patient that was a female patient, 47 years old, with repeated attacks of melena more than 6 times and progressive anemia in between attacks. She received within 1 year more than 30 units of blood. She performed the upper endoscopy, colonoscopy, barium studies, and the angiography, and all of them were negative. Hemoglobin dropped to 6.4 gram per deciliter. And when she performed capsule endoscopy, we found that bulge that would present at the mid-jejunum, and that bulge had an ulcer on top of surface. That's a gastric tumor, and the patient performed surgical resection, and that was the picture. 90% of the gastric tumor was bulging out of the lumen and 10% just inside the lumen, and after resection she never bled again. So she was not in need for further endoscopic techniques. She needs to be managed immediately by surgery. Second patient, 27 years old with persistent and progressive anemia and chronic diarrhea over the last 5 months and weight loss. Hemoglobin dropped to 2.9 gram per deciliter, was microcytic anemia. Upper endoscopy just mentioned the presence of refluxoesophagitis, gastritis and duodenitis, and normal colonoscopy. He performed a barium meal follow-through that was negative, barium enema that was normal, and even CT abdomen with contrast that was normal. And when the patient performed a capsule endoscopy, we found that picture, this first one, we thought that we are still in the stomach. After passage of 1 hour and 2 hours, we had the real-time viewer at that time. And so we thought that we are losing our time recording in the stomach. So you can see the second picture, that the tip of the scope, we tried to do endoscopy or endoscopy to catch the capsule and just to push it through the pyloric ring to continue. But we found that these pictures were taken from the duodenum. The patient had total villus atrophy, and that gives the appearance as if we were in the stomach, but it were in the duodenum, and the patient he took biopsies at the time, and he proved to be a celiac disease. And to compare these pictures to the normal one and the villus patterns that we are expecting to see, these are the normal villus appearance. And so the patient, after duodenal biopsies, was diagnosed with celiac disease, and he was on a diet management and gluten-free, and he improved. Our third patient, old male, 78 years old, with upper endoscopy and colonoscopy that were non-conclusive for a source of anemia, and he took blood transfusion several times. And we found such lesions. These are the angiodysplastic lesions that were present, and the patient, of course, proceeded for push enteroscopy and EPC cautery because they were present in the proximal jejunum, so he was not in need for double balloon. Again, but more difficult case is that the patient, 53 years old, with obscure GI bleeding and recurrent melena, anemia and blood transfusion, several sessions of upper endoscopy and polypectomy for polyps that were not convinced as source of bleeding. So we found these lesions that was in this picture, one lesion, second, third, fourth, and in such picture you can find that more than 10 lesions that were present with angioectatic lesions, and that was a troublesome case because it was not possible to cauterize. There were more than 100 lesions. It was a difficult case. Then this first patient, 89 years old, with iron deficiency anemia and melena, normal upper endoscopy and history of angioectasias in the colon. So we were performing capsule endoscopy, thinking that possibly we will find other angiodysplastic lesions that will be present within the small bowel, but we found that lesion, that large lesion that was present in the late jejunal region, and it was of a malignant nature, and the patient was referred thereafter for double balloon enteroscopy because the lesion was very tight and the capsule didn't pass. He performed a capsule retrieval, they took biopsies, it proved to be adenocarcinomas, and then he proceeded for operative resection. But he had a problem because of his age. He was 89 years old. We didn't follow thereafter. Male patient, 16 years old, with recurrent melena, history of car accident, upper endoscopy done twice that showed the presence of ulcers, and another third upper endoscopy that with performance of hemoclip for vascular duodenal lesions. And when we performed capsule endoscopy, we found that hemoclip that was inserted before. Then we found the presence of longitudinal ulcers that were present in the terminal ileum and prominent Peyer's patches. So we suspected for Crohn's disease. He performed a colonoscopy with deeper intubation. He took biopsies and he proved to be Crohn's disease. So he started a medical management. Seventh patient, about 70 years old, with obscure GI bleeding and no source of bleeding and long history of NSAIDs. So it's important to take histories, of course, of the patient, and we can see pathognomonic lesion that we find in some cases with NSAID enteropathy, the presence of what we call it the diaphragmatic ulcer. That's an ulcer that takes all of the circumference of the lumen. It was present, and even it led to slowing of the capsule at the time, and it stayed at that region due to a limited stenosis for around 2 hours. Then it passed thereafter, and it was due to NSAIDs, so the patient just needed medical treatment and to avoid NSAIDs. Before last patient, 45 years old male patient with hemoglobin drop to 7.7 with repeated bleeding. Again, history is important. Extensive jejunal versus. He did resection to a part of the jejunum, and he is diagnosed with Klippel-Tremonowny syndrome. And we found very, very numerous ectopic versus that was present in the jejunum and the ileum. And the patient, of course, he had to be managed to reduce the portal pressure, and we referred him for liver transplantation, but we don't know if he proceeded or not. So in conclusion, obviously capsule endoscopy enabled the diagnosis of many lesions that were difficult for diagnosis. It's clear that it added an excellent tool for simple and easy diagnosis for small bowel lesions. It has a high diagnostic yield and positive clinical impact, and the use of capsule endoscopy and double balloon enteroscopy is complementary to each other in some cases, with a guide of the capsule endoscopy for the potential lesion that needs therapeutic management, as well as the best route to reach the lesion. And thank you very much.